This is Chapter 23, Rehabilitation of Foot and Ankle. In order to appreciate the rehabilitation, we must first have a refresher on the anatomy. As we are talking about the ankle and the foot, there are multiple joints to discuss. First is the talocrural joint, which is the tibia and the fibula against the talus. This is known as the ankle mortise. To be consistent with the book, we will say that dorsiflexion and plantarflexion are at the talocrural joint. What we call inversion and eversion is at the subtalar joint, which we will get to soon. But what are the norms for dorsiflexion and plantarflexion? It's good to have that in mind when considering the early part of the rehab plan. When we do the half-kneeling dorsiflexion, what is considered appropriate on the goniometer? How about a less specific method like distance of the knees past the toes? Since the ankle is a commonly injured area, hopefully the ligament names are easy to remember. I have links to pictures in the presentation to remind you if you forget. Also, it is important to remember the muscles and their motions. I have my lower eval notes linked at the bottom for a quick refresher. Knowing how they are situated by compartment should make remembering their function easier. Next, we will talk about the subtalar joint. Like the name implies, it is below the talus, which is where it articulates with the calcaneus. As I mentioned earlier, the book discusses this joint as where inversion and eversion occur. A good representation of that is around 155 of the video linked to the inversion-eversion line. The motions of pronation and supination are triplanar, which makes them a little more complex. Do not get too hung up on the specific motions of the talus and calcaneus listed on the slide. Think more about how it shows up in your foot motion during weight bearing. When you are a supinator, what part of your shoe is worn? How about when you are a hyperpronator? Check out the hyperlinks to see if you are correct. Visualize the foot wear pattern. Then the motions listed as foot movement should make sense. I put foot in quotes because those motions are coming from multiple joints. The mid-tarsal joint consists of two articulations, the calcaneal-cuboid and the talonavicular joints. We will get into its significance in the next two slides. I have what looks like a confusing flowchart and pictures, but I'll try to make this simpler. Think about how all this appears clinically. If the mid-tarsal positioning leads to a forefoot varus, what do you think the weight-bearing pattern looks like on the shoe? Hyperpronation. So the wear pattern is on the inside. If the wear pattern is on the inside, what will the arch of midfoot look like? Probably pretty pes planus. Falling to the inside of the foot puts the proneus longus in a disadvantaged position due to a change in the cuboid position, decreasing the stability of the first metatarsal. About first metatarsal stability, you start to toe off on the second and third metatarsals, which is not what you want. The metatarsals spread out and you can get bunions, bunionettes, calluses, or stress fractures due to excessive load to places that cannot handle it. Again, think about this slide clinically also. If the mid-tarsal positioning leads to a forefoot valgus, what do you think the weight-bearing pattern looks like on a shoe? Supination. So the wear pattern is on the outside. If there are supinators, what will their arch or midfoot look like? Probably a pes cavus foot. When you have pes cavus, the lateral and medial borders are stressed. The lateral because that is where you're putting all your force when you're ambulating. The medial is stressed because that first ray needs to be incredibly rigid while the head of the first ray points inferiorly. There's a plantar flex ray to overcome the pes cavus and toe off appropriately. If you think about what the ankle would look like, you could see that it is in a position where you are set up for chronic lateral ankle sprains, since you are in a position of subtalar inversion due to the pes cavus. Moving distal in the foot, we have the tarso-metatarsal joints. Cuboid and the three cuneiforms articulate with the five metatarsals. They can rotate in weight bearing. These are commonly called Lisfranc's joints. If you've heard of a Lisfranc sprain, which you should have, these articulations are involved. The most common mechanism of injury to these joints is a hyperplantarflexion at the ankle where the limits of sagittal plane flexibility are exceeded. Other joints we will mention are the metatarsal joints. The first and fifth are free moving, while 2 through 4 tend to work as a unit. As you know, the first ray is where the gait cycle goes through to propel a toe off when an individual has appropriate pronation. That is why you have muscles specific to the first ray and great toe. I mentioned it earlier, but what muscle is important in stabilizing the first ray during ambulation? If you do not remember, look at the forefoot varus slide again linked in the text. Fifth metatarsal also has subtle movements when the ankle plantar flexes and dorsiflexes. If you do that and look at your fifth met, you can see these. It adducts and inverts in plantar flexion. That is why it looks like your foot rolls in when you point your toes. Does this make sense when we talk about the common lateral ankle injury mechanism? It should. It adducts and everts in dorsiflexion. The fifth toe sometimes exaggerates these motions. As I stay at the bottom of this slide, the information on the slide should be familiar. I copied it verbatim from Chapter 1. With any rehab protocol, these issues should be addressed, although not necessarily in this order. There's a reason why we talked about these things first in class instead of jumping to the body region chapters. This slide should also look familiar. This is verbatim from Chapter 2. This is a pretty good template to follow when doing any rehabilitation. The timing of what you do when will be very different for the various injuries you come across, but the healing process always follows the same progression. If you look at the various concepts we have learned from the last slide, you can plug them into what you do while in the various phases of rehab. Modalities, taping techniques, and manual-therapy, including the mobilizations we discussed, are also involved in this protocol. This last slide is simplistic, but that is by design. For our discussion, we will be going through these phases as it concerns the foot and ankle, and filling in the gaps of what you will do in different injury states. How do you know where the patient is in the rehab process relative to these phases? Is there a set protocol or cookbook? Definitely not. That is where your evaluation skills come back into play. Those progress notes and reevaluations give you the information you need to figure out an appropriate rehab protocol. That is where the information in the last slide comes into play. You use your evaluation skills to determine the patient's status. You use your modalities, taping, manual therapy knowledge to put them in the most optimal position. Then you use what we have talked about in the first half of the semester to pick the appropriate exercise to fulfill those benchmarks. Lucky for you, there are over 5,000 exercises that you can access in Simple Set, making your arsenal of exercise a little broader than most athletic training students around. So, this should give you a primer for what we will talk about for the week with foot and ankle. Keep these concepts in mind, especially the 6th and 7th slide. Those slides are going to be a template for any rehab that you do.